Good morning, Indiana Sepsis Champions. This is Becky Hancock from the Indiana Hospital Association. We welcome you to the third of our series on sepsis in Indiana across the continuum of care. Today's webinar is on post-sepsis syndrome and readmissions. So welcome to our webinar. A few navigation items. Please keep your phone on mute or your speakers silenced on your computer so that we don't hear background noises. You can access the chat room by putting your scroll bar, your pointer up to the top of the screen, and a bar will stop down, and click more and you can open the chat room. Please type in your name and your facility so we know who all is in attendance. And you can use the chat room. We will be monitoring it during the webinar so that we can see any questions that pop up and address those. So welcome to our third series webinar. And bear with me a minute, I'm having a little bit of trouble. There we go. So just to refresh you on our mission here at the Indiana Hospital Association: prevent patient harm, increase patient and family engagement, improve community health, and lead a culture of safety. On the right-hand side is a map of our state with all the different 11 patient safety coalitions across the state that we are liaisons for, some of which we lead, some of which are led by other people, but this is where we get our work done across the state. So this is a statewide webinar, but much of the work is done within these different coalitions across the state with their mostly bi-monthly meetings. Sepsis Across the Continuum is the webinar series that we have going on from November of 2019 through February of 2020 with a monthly webinar. We are in the January term with post-sepsis syndrome and readmissions. The other two webinars are available via the hyperlinks that are noted on this particular slide. The slides will be posted as well as the recording. All of our information for our sepsis toolkit, as well as all of our webinars, are on the survivesepsis.com webinar website that's on the right-hand side, so you can access anything there that we have recorded and shared. I also want to point out our archives at the bottom of that page, including the 2018 Preventing Hospital-Acquired Pneumonia, Non-Ventilator Pneumonia by Joanne Brooks, which is key to reducing hospital readmissions for pneumonia. Our call to action for our sepsis screening webinar was to assess your emergency department and inpatient areas for your sepsis screening and rapid treatment processes, plan a community education event to reduce time to treatment, and educate your hospital staff to be leaders in sepsis awareness. That was December. In November, we had a call to action around bundle compliance. To take a look at Dr. Kaiser and Casey Barnett's podcast on survivesepsis.com website for strategies to improve your bundle compliance. Again, plan a community education event to reduce time to treatment, and develop a plan to improve your sepsis bundle compliance. If you're above the Indiana average, seek toward the top decile of 79%, and if you're below the Indiana average, state average, or the national average of 59%, then you should be shooting for at least reaching the national average. Last year, there was a House Enrolled Act number 1275 that was passed by our state legislature. That act is posted and available through the hyperlink on the title of this slide here. And from that, there's an ISDH task force that has been formed and has been meeting since April. The continuum of care is represented for that within that task force, including school nursing, state medical association, emergency department leaders, primary care, home health, hospice, all across the continuum. From that, we are working with how we're going to prepare education for the hospitals in the hospital subgroup. Last week, we emailed to sepsis leads and CNOs a sepsis gap analysis that's due from hospitals on January 31st. You should have received that. Someone in your hospital, we have a list of sepsis leads, and that's where it went first. From that, we will use the gap analysis to identify best practices and innovations within the state and use that to work with hospitals who are still having opportunities. We will also develop a library of resources, because much of the resources that are being used oftentimes are not yet in the EMR, and people are resolving to use paper tools to get until the EMR gets updated. So we've asked that you also send us your documents and education, as well as tools that are using for success, so that we can create a library, and those should be sent to me. For the sepsis survey, please, we included a PDF of it, but please be sure and enter your PDF into the Survey Monkey that's available within the email link that we sent you. For a couple people have sent us their completed PDF, we prefer you enter, and I will go ahead and enter those, but just a note to please enter them in Survey Monkey. A couple items on the survey are related directly to the sepsis law that was passed in 2019. And two things, the State Department of Health is to adopt model guidelines based on recommendations of the task force, and two, coordinate, develop, and implement sepsis guideline training. So that's a lot about what we are doing and what the survey is about. It also requires hospitals to adopt, implement, and periodically update their sepsis guidelines for early recognition and treatment of patients. It also expects that a hospital submit sepsis data as required by CMS to assess their compliance with the sepsis bundle. These are some of the questions that are on the survey, and we will be working with hospitals who still have opportunities within those particular areas. There will be, if the State Department, if you have your survey, they may ask if you have evidence-based sepsis treatment guidelines. And if you're following the CMS guidelines, that is the expectation, is fine. You may just have to show them a copy of that. Our objectives for today are identify the symptoms of post-sepsis syndrome, describe our hospital sepsis readmission rates for the state of Indiana, and identify discharge educational strategies for patients with sepsis. We have a polling question, and if you would please take the first one and the second one. Does your facility have a staff person with dedicated time to coordinate sepsis activities? So if you would please respond to these two polling questions. And the second one is, does your facility have standardized patient discharge education materials for patients with sepsis? So if you would please take a minute to respond to both of these polling questions. Okay, we'll go ahead and end polling now. Casey's going to read us the responses here. A few more people still answering. We'll hold off a moment. We'll keep the polling open for a moment here.
That's kind of
low volume.
For the first question, does your facility have a staff person dedicated with dedicated time to coordinated sepsis activities? We've got about 18% with no person dedicated to coordinated sepsis activities, 11% with a sepsis coordinator solely dedicated to coordinated sepsis activities, 68% staff person dedicated to coordinated sepsis activities but with other responsibilities, and 4% other. The second question, does your facility have standardized patient discharge educational materials for patients with sepsis? 54% yes, 32% no, and 14% unknown.
Thank you very much. I think you'll have some ideas of where to go with this content as we continue with this webinar. Having some technical difficulties progressing the slides here for a moment.
I think I need to end it.
Bear with us here for a moment.
Still not ready.
There we go. I wanted to make sure that you are all aware of, some people have participated in our, some of our other webinars and are well aware of the podcast that we did. Particular podcasts of interest for this particular webinar are on the survivesepsis.com website, but I wanted to point out an excellent webinar by Dr. Lindsay Weaver on My Infection Becomes Sepsis, the top left one.
I'm sorry.
To the right is Sepsis Treatment Successes with the Joint Commission Certification by Casey Barnett, who's also going to talk about sepsis patient education at the end of this webinar. Sepsis Survivors Rehabilitation Research, working with patients on their cognitive and physical and psychosocial rehabilitation program that's being done in Eskenazi, and that helps identify the needs of patients. It is a research project in clinic in process. And lastly, on the bottom right, sepsis recovery, a podcast by Suzanne, who is a lived experience patient who's sharing her story, which I'm going to read here. So Suzanne is our Connect to Purpose story for this, and I'm just going to read excerpts of what she shared with us in 2016. 7 months ago, I became a survivor of severe septic shock. 7 months ago, I came home from the hospital after many days in ICU. 7 months ago, I didn't realize I was going to be the first of many days at home recovering and trying to become normal again. 7 months, I've been scarred for life. I now live with PTSD, anxiety, depression, pain, and heart issues, just to name a few. I am convinced my life will never be the same. I can't even walk from one room to another in our house without becoming exhausted. Everyone has just expected me to be back to myself, but I haven't even had the time to recover completely. The second I left the hospital, I had to step up and be a mom for my boys. Yeah, I try to take it easy, but let's be real. For me, that isn't an option. I wonder why God chose to save me. I will be brutally honest. Some days like today, I wish He didn't. No, I'm not suicidal. I'm real. If people could just understand the daily struggles I now have to deal with because of it all, you would understand why I say that. I'm so thankful God saved me because I know He has a plan for my life. I never doubt Him. It's the human in me that just gets me down. Today I was pretty much told I will never be the same again, all thanks to sepsis. This is about 7 months out from her illness. I want to point that out. I mean, I guess I pretty much died and my organs were failing, so what should I expect? My body has been through a lot of trauma. What people don't realize, though, is the emotional, mental toll it all took on me as well as the physical. I still have nightmares of when I got a central line in my neck and had issues breathing, or from when they needed to do a central line directly into my artery in my arm that goes through the nerves, and I was screaming bloody murder from the pain, the excruciating pain I was in all over my body, or having panic attacks and having to be giving medicine to calm me and force me to sleep. But now I don't sleep. I have anxiety, panic attacks every single day that I have to walk myself through. I question a lot of things. I sit and cry because 2 people died this week from the same thing. Also knowing that my husband's aunt died from the same thing. She was only in her 40s. That really hits close to home. I will never in my life forget any of it. I guess what I'm trying to say is I am not okay. I'm still recovering. I need help. I need prayers. I'm tired physically and emotionally. I'm depressed. I don't want judged. I just want to feel like someone cares. I know there are people that do, but again, days like today, I feel completely alone. Everyone is always so caught up in themselves. Sometimes I'm even guilty of that. It's time I take care of myself. If you think about it, say a little prayer for me. I feel alone. I need strength. So that was in 2016. In September of 2019, we checked back in with her, and she said, now that I survived a year of life after sepsis, I feel like I'm getting stronger. I'm able to move on in my life and start breaking the hold that septic shock has on me. My biggest frustration, I still cannot do everyday tasks without getting exhausted or having to take breaks. I still do not sleep, nor do I have much of an appetite. I fight anxiety daily that I feel will never get better, no matter how long it's been around. All around, I'm more and more thankful every day for surviving despite everything I have to live with. In December of 2019, we checked in with Suzanne. I let her earlier this year, let her know that we were going to share her story, and she said, I just want you to let you know I'm 12 weeks pregnant. So this is the full cycle of her recovery. Not full cycle. I'm sure there's still things going on, but we're so excited at Suzanne's progress and know that recovery from sepsis takes time, and she shared our story so that we can move care forward. We're going to talk about sepsis readmissions and about post-sepsis syndrome in this particular webinar, but a few points out. In Indiana facts, over 20% of sepsis patients are readmitted within 30 days in the state of Indiana, and it is the most frequent inpatient discharge aside from deliveries. It's very costly, with average charges more than $51,000, and more inpatient deaths from sepsis than any other diagnosis. So how are we doing with our readmissions in general here in the state of Indiana? We have our HIN project, Hospital Improvement Innovation Network, going on, and from that we're tracking progress toward our goal of 12% reduction in readmissions during the HIN. Project to date, we are at 2.8% improvement. In the last 12 months, if you just look at the last 12 months compared to baseline, we're 1.8% worsening. So something's happening from September of 2018 roughly all the way up to the current, the last 12 months, that is driving hospital readmission rates higher. It is not unique to Indiana. It is across the nation. They're aware of it. We are aware of it, but we need to make further progress, and I have a recommendation later. So within our Indiana readmission rates, you can look at it two different ways. Medicare usually drives the readmission rates, but in this case, this is information from DataLink that you have access to within your hospital. Your quality department and your CNO have access to this particular DataLink resource. So we're happy to do a webinar to teach you how to use it. But what this shows is that a similar line is what I showed with the HIN. This is all state picture. The Indiana readmission rate was running about 9% in 2016, and now we're running at 8.29%, 9.1 down to 8.3%. So that is some reduction there in general in the all readmits. When you look at the Medicare population, we've gone from 12.6% to about 12.12% in the last first quarter of 2019. And again, the HIN progress that I showed on the previous slide is relevant. Just to expand a little bit that, this is particularly all payers as opposed to just looking at Medicare, and so we want to include all patient populations and ages in our assessment. Overall readmission rates are at about 8% right now for the state when you take out same-day transfers. Not really bad, but what can we still do to improve that? Well, what we did was we ran data for all Indiana readmissions by the top 10 most frequent MS-DRGs. And what we know is that the number one DRG for readmissions is MS-DRG 871, which is sepsis without mechanical ventilation, but with a major complication code. Number one is 871. Number 10 is 872, which is septicemia without mechanical ventilation and without a major complication code. But I also want to throw in there that 193, the second one from the bottom, is simple pneumonia, and which may have an impact with the sepsis. So what are we doing with our sepsis readmissions, and is that actually driving a lot of our volumes that we haven't really addressed sepsis readmissions in the state? CMS has not asked us to work on. They've asked us to work on AMI, heart failure, pneumonia, and COPD readmissions. But if this is driving all-cause readmissions, what can we do to improve care for our patients to prevent them from coming back in the hospital after they've had a diagnosis of sepsis? And this data is from 2018. What we do know, so we keep a look at what's going on within our state, but we also keep an eye on the literature too. And buried between the literature and what's going on in our state is the innovations that we share. And that's what we're trying to do today, is share some content around innovations that are going on, but still keeping an eye on the literature around sepsis. So what we know is that surviving patients who passed the bundles had lower 30-day readmission rates of about 5%. Does that matter? Well, we believe that it does. 40% of sepsis patients were readmitted within 90 days for conditions that were treatable as outpatients, such as another bout of infection. This data came out in January of 2018 by Prescott. It's very hard to get sepsis data because you have to really do some chart reviews to actually get at it oftentimes, but just pointing out 40% of patients are readmitted within 90 days based on the literature review. What makes a difference? In a recent abstract that was published within the last few months, there were effective audit and feedback on physician adherence to clinical practice guidelines for pneumonia and sepsis. And what they said was that feedback with blinded peer comparisons, how are my peers doing? What areas am I missing? Significantly improved guideline adherence from 52% without feedback to 65% with feedback. That's really about where we are in Indiana. We're at 53% for the state based on 2018 data from Hospital Compare. So what can we do? Well, one option is this feedback with blinded peer comparisons. They also mentioned nursing handoff tools are critically important to ensure the seamless, timely care for patients, and that we need to layer multiple strategies to maximize sepsis care. So it's not going to be one activity. It's going to be multiple activities that address care across the continuum and during the hospitalization. So, opportunity, feedback to clinicians. What we do know is that the volumes of patients are going up over time. And there are two different ways to look at these volumes, and this data is available for each of your hospitals through DataLink, our IHA application for looking at our inpatient discharge study data. And what it shows in two different views. The ICD-10 diagnosis with primary or secondary diagnoses of sepsis. In 2018, we were at 49,000 patients. If you just take a look at the primary DRG of APR DRG 720 of septicemia, with those patients who had a primary diagnosis of sepsis, that brings it down to about 35,000 patients. So that's a difference of about 14,000 patients. About 14,000 patients fall in the secondary diagnosis of sepsis. We want to make sure that we're addressing not only those patients who come in through the ED, get a primary diagnosis with sepsis present on admission, but also those who are developing sepsis during their hospitalization. Because if we don't get on the sepsis bundles during their hospitalization, when it's a not present on admission sepsis for inpatient screening, we may miss the boat on getting their bundle compliance met. However, we are making tremendous progress with APR-DRG 720 mortality rates. We've been tracking this since 2008. In 2008, the percentage was 15% mortality rate. In 2019, for the same DRG, the mortality rate was 4.75%, which is a 69% improvement in our sepsis mortality over 1 decade. Again, these are the patients who have a primary sepsis diagnosis, most likely walked in through the emergency room, got identified with sepsis present on admission. So we started treating them from the point of admission with sepsis, the principal DRG. And that makes a difference as compared to the primary and secondary mortalities. Primary and secondary sepsis diagnoses, especially those secondary diagnoses, are having higher mortality rates. But anyway, just a point of positive treatment through second quarter of 2019, we're at about 5% statewide. This is also can be used to benchmark within DataLink. So a recent study that was put out by the University of Michigan, and what they looked at is what were the patients coming back in for? Well, 29% of the patients were coming back in for sepsis, with 29% of those being urinary sepsis, also 20% gastrointestinal sepsis. 69% of the patients were treated at the readmission for infection at the same site as their initial hospitalization. And 19 to 53% were treated at the same site and the same organism. What can we do on discharge to ensure that their going home therapy is proper and that we can prevent this readmission, as well as giving them good education about what to watch for? Half the readmissions are noted there, gram-negative, gram-positive, and culture-negative results. That culture-negative, that's a concern. 34% had an unclear origin of their readmission. That's consistent with data that said that 22% of patients from Kumar in 2006, 22% had unknown source of infection. We also know that they're talking about redoing the ICD-10 codes to get them more in less specificity with the type of organism that's growing and grow more with the gram-negative, gram-positive organisms. And that's pending right now, so there might be some adjustments to ICD-10. But what I wanted to make sure you're aware of is that septicemia, severe sepsis, or septic shock readmission rates are running at about 29% for sepsis. So when the patients leave, what is it they did not know that may have helped them? In the 2015, and I know some of you who've been working on the sepsis subgroup out of the South Central Coalition have seen this article. I've shared it in many of the programs that I do. There are 5 themes that patients did not know when they left the hospital based on a qualitative analysis of these interviews. They did not have an awareness and a knowledge of severe sepsis. They didn't understand the experience of the hospitalization for sepsis, the ongoing impact of severe sepsis, and the impact on caregivers, and the support after severe sepsis that they needed. I think that our story, that our narrative that Suzanne shared, greatly highlights each one of these items as opportunities to improve our discharge education for our patients, in turn to continue working on post-sepsis syndrome items, as well as reducing readmissions. So I know that many of you are working on sepsis discharge education out there, and we'll hopefully have, Casey's going to present a little bit, Barnett from Terre Haute Regional is going to present a little bit about what they're doing later on. So what is post-sepsis syndrome? This was identified early in 2018, and it's kind of a subpart of post-ICU psychosis, post-ICU syndrome. But the literature's coming in about the most specific things that are sepsis-specific, like what Suzanne described. Many of the symptoms she described were specific for post-sepsis syndrome. So what are we seeing? We're seeing an average of 1 to 2 new functional limitations, such as the inability to bathe, and this greatly impacts caregiving for patients, as well as those who may not be caregivers, but just the family members and what they're not able to do that they may need further help with. There's a threefold increase in moderate to severe cognitive impairment. Dr. Babar Khan's rehabilitation clinic is working on determining if cognitive rehab can be improved. It can improve the cognitive impairment that occurs. And there's a lot of continuing dialogue right now about does delirium and cognitive impairment in the hospitalization trigger dementia in the older adult population. A lot of research going on with that right now. But these patients have a high prevalence of anxiety at 32%, depression at 29%, PTSD at 44%. And Suzanne came up with all these terms based on what she'd learned post-hospitalization. This article wasn't even out when she had written her content. She stood up at one of our meetings and said she decided to come to hear our content in early 2018, I believe. And she stood up and she said, I'm a sepsis survivor, and I am just so glad to know that I'm not alone. It's not just me. So patients need to understand on discharge what it is that may be happening to them that's attributable to their illness and potentially overcomable, not thinking that this is going to be their life continued with all these post-sepsis events. One thing that Dr. Kaiser, who's from Columbus Regional, did a webinar for us, a podcast for us in September with the rest of the September podcast. He noted that you need to get your patient back to their euvolemic state before discharge to prevent CHF readmissions. I thought this was a key point that I wanted people to hear so that we know that the issue with the bundle compliance around volume infusions is key, but it's important to know what their euvolemic state is so that we're not leaving patients with too much fluid when they leave the hospital. We did our polling question already. Does your facility have standardized patient educational discharge materials? And 54% said yes, 32% said no, and 14% said unknown. I do believe this is an opportunity that we can improve upon, and when we get our data back from our survey as well as sharing, we will be sure and share that information. There's also a tremendous amount of educational materials available through Sepsis Alliance at sepsis.org, which we'll get to in a little bit. So in addition to the sepsis, post-sepsis syndromes, CDC has a life after sepsis fact sheet that can be used. And what we know is half of the patients recover, a third die, and a sixth have persistent impairments. I think we're doing better on the one-third dying during the following year compared to this data, which was probably from about 2016, maybe right after the guidelines were implemented. And I just believe that we're doing better. And so we need to rerun this data, but again, Prescott at least got the information out in 2018. So 2 places to get your information about life after sepsis. One is the CDC, and the second is sepsisalliance.org, which is also sepsis.org. This is a flyer that you can look at and can share with your patients. The functional impairments that the patients are experiencing: functional limitations, cognitive limitations, anxiety, depression, post-traumatic stress disorder, chronic illness exacerbation, increased mortality, and longer hospitalizations and ICU stays. These are concepts that when the patient comes in with sepsis, we can be aware of these and include these in our post-discharge education. I'm going to pull up a video now about life after sepsis, and let's see, make sure this works.
Too high. More patients are surviving sepsis each year. Sepsis is an important public health threat. Every 20 seconds, someone in America is hospitalized with sepsis, a life-threatening illness caused by an infection. While mortality rates are still too high, more patients are surviving sepsis each year. Now, more sepsis survivors are discharged from our hospitals than ever before. However, after sepsis, patients often experience new problems that may continue for years. Common problems after sepsis include difficulty with memory or concentration, anxiety and depression, weakness and difficulty completing routine tasks, such as dressing and bathing. Recurrent infection, setbacks in the ability to control chronic heart, lung, and kidney diseases may result in additional hospitalizations. As a result of these problems, many patients may have difficulty returning to work, returning to school, and doing their usual hobbies after surviving a hospitalization for sepsis. If you are a sepsis survivor, you are not alone. If you are experiencing forgetfulness, poor concentration, weakness, anxiety, or depression, spouses and family members are often affected too. Many serve as caregivers, helping their loved one with dressing, bathing, organizing medications, and attending doctor visits. This is a stressful time, and many family members report feeling depressed or overwhelmed. Unfortunately, setbacks in the weeks after sepsis are common. 1 out of every 4 sepsis survivors will be rehospitalized within 30 days. The most common reason for hospital readmissions is an infection. We at Sepsis Alliance and the Society of Critical Care Medicine's Thrive Initiative are committed to spreading the word about sepsis survivorship and supporting the recovery of sepsis survivors and their families. We recommend the following 5 strategies to improve recovery after sepsis. 1. Providers, patients, and families should raise awareness of the long-term consequences of sepsis, including the risk for further medical setbacks resulting in hospital readmission. 2. Patients, doctors, and families should carefully plan for hospital discharge. Medications are often started or stopped during sepsis hospitalizations and may need to be further adjusted in the weeks after hospitalization. Everyone should be on the same page and know why each medication was stopped or started to avoid mistakes. 3. It is important that patients follow up with their primary care clinician shortly after their hospitalization and know who to call if an issue arises before the first follow-up visit. 4. After sepsis, many patients have new weakness, difficulty completing routine tasks, and reduced stamina. Patients must work to get stronger. Depending on the severity of the problems, patients may need rehabilitation, physical therapy, or a structured exercise program to follow. All patients will need to work to increase their activity in the weeks after sepsis. 5. Further health deterioration is common in the months after a sepsis hospitalization, most often caused by another infection. Patients should seek medical attention for signs and symptoms of infection. Physicians should be aware that risk for recurrent sepsis is very high. Help raise awareness of sepsis survivorship. The lives of millions depend on
it. Isn't it great that we have so many sepsis survivors that we have to improve our care for sepsis survivor patients? It's just wonderful. So we didn't really expect this to happen and didn't really plan for it. We wanted to reduce mortality for sepsis, but now we've got sepsis survivors out there, and Suzanne's story tells such an important message to us. And so this video says it better than I could, so I wanted to share that with you, and the hyperlink for this is also at the end of the webinar. It's a YouTube video, so you can access it, as well as one for older adults that I've got hyperlinks for at the end. So some other items regarding setting goals of care for surviving sepsis. Out of the 2016 guidelines, it was recommended that goals of care and the prognosis be discussed with patients and families. Goals of care and prognosis. Patients are leaving the hospital and caregivers are, during the hospitalization, they are not aware of the severe potential for negative outcomes related to sepsis. Some anticipatory guidance along the way during the hospitalization is key so that they're not blindsided at the end of their hospitalization with perhaps a mortality or any of these limitations when they leave the hospital. We know what happens with sepsis patients. It's okay to share with them the potential with the severe diagnosis. We had a family present to one of our committees that their loved one had died, and they were so upset because they really had no idea, did not hear, it may have been presented, but did not hear that the patient could potentially die from the infection that they had. So we need to be very forthcoming about the prognosis and the potential outcomes for that patient. Preparatory, anticipatory guidance reduces the surprise factor at the end. We recommend that the goals of care be incorporated in the treatment and end-of-life care planning utilizing palliative care principles where appropriate. Strong recommendation out of the 2016 guidelines. Again, what are our goals of care for this individual patient? And we suggest that those goals of care be addressed as early as feasible, but no later than within 72 hours of ICU admission. It was a weak recommendation, low quality, but at the same time they opted to put it in those guidelines. What are the goals of care for this individual patient? It is not our clinician's decision to make what are the goals of care without discussing it with the patient and or the family about what are the goals of care. What is the post-hospital focus needs? And we touched on a little bit of these already. Evaluating and reducing the risk of medical setbacks by identifying new cognitive, mental, and physical problems, also psychosocial problems. Reviewing the medications and getting them appropriate for their current level of care. Evaluating any treatable conditions, new or worsening infection, heart failure, renal failure, aspiration, sepsis, palliative care, and timely evaluations. One item that we've asked all hospitals to do through our September sepsis awareness was improve community and staff awareness about what sepsis is, the symptoms, and the timely treatment, and support programs out in the community. We also asked for them to outreach to the extended care facility. It's perhaps their greatest admission source for patients. We had a beautiful story in our last webinar by Clark Hospital, and Judy Brougham had reached out to the one facility that they were getting a lot of sepsis patients from and greatly improved time to treatment to the point that the ED physicians were recognizing earlier the capability of improving outcomes for their extended care facility patients because of the education she had provided there. In 2018, an article was published that said, actually, sepsis is a preventable public health problem. And this is the direction that a lot of the task force is taking for the state of Indiana, that primary prevention of immunizations, the flu, we know the flu can turn into the pneumonia as it's happening right now, and especially in pediatric cases, to be sure that flu and pneumonia vaccines are up to date. Hygiene, hand washing, public awareness, antibiotic prophylaxis as necessary, and managing the risk factors for patients who have high risk factors who may be at risk of sepsis and having them aware of those potential outcomes. Also, dialysis patients are participating in NHSN in a small amount out there to determine what kind of infections are occurring because dialysis patients are at higher risk of infections. So sepsis is a preventable public health problem as of 2018 in this particular abstract that they shared. Greg Martin, who wrote this, actually was on the original sepsis guidelines. So the docs that did the guidelines are coming out with new editorials, new perceptions of continued care that's necessary and continued research. Risk factors for sepsis. This identifies the patient population that are at risk for sepsis and do need further education about the potential for sepsis. Recent UTIs, pneumonias are an operative event. Diabetes. There's an excellent article by Clark on immunosuppressive therapy in patients who developed sepsis even though when they were immunocompromised, and why they did not seek care in a timely manner even though they knew that they were potential for sepsis. It was highly likely they would develop it. I'd be happy to send that Clark article to anyone who is concerned about their oncology patients in particular. Elective surgeries, chronic renal failure, alcohol abuse, splenectomy, and also non-modifiable risk factors like the very old or young, males more than females, and African Americans more than whites are more likely to develop sepsis. So when we talk about prevention and post-sepsis syndrome and preventing readmissions, if we can just work with the two most common readmissions of respiratory, pneumonias, and genitourinary issues, we will hit the top two for every age bracket. How do we prevent respiratory infections, and how do we prevent urinary tract infections? And how do we keep an eye on patients so that they don't evolve into abdominal infections, skin, and wound infections? Well, let's take a little deeper dive on that. Sepsis is often referred to as a trash can diagnosis because many things fall under that diagnosis. But what we need to do is look at those individual sources of infection and how do we prevent the recurrence of that for our patients to prevent readmissions. Again, noted earlier, 22% of sources are unknown. But I think we can make a difference by addressing respiratory and genitourinary. So how do we add life after sepsis? Different concepts. Hand hygiene, mobility. Decreased mobility can tend to reduce the ability to fight off infections by reducing T cells. That's been published. Nutrition, better nutrition for our patients. Again, we noted immunizations. Oral hygiene. I'll mention a couple items here from Dr. Joanne Brooks' presentation. Address those specific post-sepsis symptoms that the patient's having. I'd like to see someone develop a tool to identify what post-sepsis symptoms are present, and so that they know which ones they need to address. That would be a great opportunity for some nursing graduate degree. Hydration, keeping our patients well hydrated to prevent urine concentration, which can in turn trigger bacterial growth. Sepsis education, sepsis source-specific education for wherever their source was, as well as medical follow-up in 1 to 3 days through transitional care management, which I'll mention in a moment. Our webinar by Dr. Joanne Brooks talked about the reduction of 70% of hospital-acquired non-vent pneumonias by purchasing and making sure that the patients were doing inpatient oral hygiene. This is work by Quinn and Baker, and it was published in the Wall Street Journal. So it certainly picked up steam after they published their work. The VA has good guidelines available that have been published, and they also had them opt to gargle within 20 minutes, brush their teeth and gargle within 20 minutes of being intubated in the operating room for elective admissions. This is key work that all of our hospitals need to be doing. They were able to reduce the death rate 15 to 31% by doing this. Pneumonia, the #1 hospital-acquired infection. We can do better. This is your teeth every 3 hours, 2 to 3 hours as the bacteria grows. Kind of disgusting. We can do better. I'm not going to go into detail about the social determinants of health here, but just know that oftentimes these infections need to be looked at on a psychosocial or social level, and what are the physical, environmental, and social determinants that is driving some of their health outcomes. This dovetails with a few of the things that I mentioned in the prevention, health behaviors, transportation to physicians' offices for their follow-up, good nutrition, and also their housing. What is their housing conditions? I wanted to share with you the faces of sepsis survivors. This is based on the research that I did back for a degree back in 2018. We do have survivors. These were the survivors who had stories to tell. We want to hear more of their stories like we did with Suzanne. Quotes, I had no clue how devastating septic shocks could be. Thanks for Sepsis Alliance for the work you do and for educating me and the public. Here's a tool that's on sepsis.org that is a patient education zonal tool that they can go home with. There was a webinar that was done in 2017 about sepsis across the continuum in home care by Sepsis Alliance, and this is a tool that they shared. Green zone, all clear. Red zone, when to call your doctor if you experience new or worsening infections. Green zone, red zone, and what is sepsis. A good tool that you can implement within your hospital. I'd like to open up the line now for Casey Barnett, who will share a little bit about what they've done as a Joint Commission certified hospital for educating their patients at discharge.
Hey, this is Casey.
Great. Speak
Thanks
up.
for having me,
Here's
Becky.
what.
Alrighty.
Yeah, thank you.
So, yeah, we became Joint Commission certified in 2017. And so since then, we've kind of really been trying to redefine our education for our patients. As obviously Becky's been mentioning how important it is that the patients understand what's going on with them, not only the patients but the family. So originally we were giving a pretty good brochure just about generalized sepsis education, signs and symptoms, and some prevention. We realized that over the years this really wasn't being effective for the patient, so we've kind of switched to a more individualized approach, hopefully getting to the source of patient sepsis and how they can prevent in the future. So what's on your computer slides is just a copy of a snippet of what we give each of our patients that come in septic to our hospital. The first one is just like what Rebecca was just talking about, a zone tool. Our nurses explain it as green, you're good to go, yellow, call your provider, and red, come to the emergency room immediately. So it really does, we encourage them to put this on their fridge or somewhere that they can see it every day, and assess how they're doing, especially those, newly discharged from a sepsis stay. And then the Sepsis Alliance gives a great tool, Life After Sepsis. It just kind of goes over how to get back into daily living, what to expect, how you may be tired. It goes over how family may be feeling. It is a really good brochure. If you've not seen it, go to Sepsis Alliance and it's right there. But we give that packet to every patient. And then each patient also gets an individualized sheet of what infection caused sepsis or chronic condition, just so that they know a little bit about it. It talks about, each sheet talks about vaccines, how important they are, hand washing. So they're individualized but standard at the same time, so that we're making sure we're covering all of our bases. So they do seem to be working. The staff are seem to be learning a lot more just in general about sepsis, the disease process, and then it seems that the patients are really enjoying the brochures. But like Becky said, and going back to the Gallup survey, patients just aren't sometimes even aware that they had sepsis during their hospitalization, because either providers just fail to mention it, family members don't want to mention it. So we're really trying to get our staff to get out in front of the patients early, as soon as they're appropriate, get them this education so that we can assess barriers and address them early in the stay. But one of the things that the article points out is that many patients point to a general lack of information of, during recovery and hospitalization. So that's something that our hospital would like to work on more, as we do see readmissions just like every other facility, and it tends to be reasoning that the patient couldn't get to their primary care provider to follow up, and they just got back into trouble, and they're coming back in with, reinfected, and so we're having to kind of start all over. So this is just the tip of the iceberg of where we want to start. Our goal is to get to where we're really following up with these patients and drilling into each of their readmissions and hopefully preventing that, and then in turn, making a mark on the mortality rate as well. So.
Thank you, Casey. Did you happen to get an opportunity to read that Clark article that I sent you?
I did, yeah, that was good. I didn't get it passed on to Dr. Schmitz though yet.
Okay. So what I really like about what they're doing there is that they're providing generic sepsis education as well as source-specific sepsis education for wherever the known source was for patients, so that they can be aware of the things that they can do preventatively for the type of sepsis that they had. It doesn't have to be stood as a trash can diagnosis. We can be more specific. I see this as like Alzheimer's disease, where you've got dementia as the umbrella and multiple different types of dementia, Alzheimer's being one of them, pugilistic for multiple blows to the brain, Parkinson's dementia, all the different types. But sepsis is a broad term related to UTIs, related to pneumonia, and those other different sources. We can do better. Casey, thank you so much for sharing. I will note that with their improvement in sepsis bundle compliance, as we highlighted in the first webinar in November, your mortality rates have greatly decreased related to the work that you've done there with your Joint Commission certification for sepsis. So, and we can see that data through DataLink, at what point you started doing your changes within your hospital. And now what we will probably see, I haven't looked at this, but I suspect that your readmission numbers and your readmission totals are potentially going down as a result of your reduction in sepsis readmissions. So if you have a way to look at that internally, I would love to hear how that's going. What are your sepsis readmission volumes compared to your overall readmission volumes, and is it driving an improvement there because of your education and improved care for the sepsis patient?
Yeah, we do correlate that data, so I can get that to you at some point.
Excellent. All right. Well, thank you so much, Casey. I'll finish up with a few more slides here, and then I want to do a little Q&A at the end, and I want other people to be able to share with me what they are doing at their hospitals related to patient education at discharge. So a quote from the families of victims: "We can send people to another planet, but we can't fix something that seems so simple. I miss her terribly. Screw you, sepsis. I know my entire family struggles every day with what ifs. Had we only known the signs of sepsis, this would have had a very different outcome." And that applies to first sepsis as well as recurrent sepsis. So continuing education does not occur once. You know we don't get it when we hear it the first time. I've been talking about doing these things for about 2 years, and I'm so excited to hear the different components of education that are being done out there, not just by Terre Regional, but by several different hospitals that I know. Transitional care management. So Casey talked a little bit about getting transportation for getting to the hospital, and we talked about social determinants of health. These are slides that were from Purdue Healthcare Advisors as we did rounds across the state back in late 2017 and mid-2018. Transitional care management coding, CPT codes 99495 and 99496, for moderate and high complexity patients. There are specific steps that you take to improve reimbursement for patients post-hospitalization during the post-acute care time period. So primary care offices can use these CPT codes to get a higher reimbursement rate for following up with these moderate and highly complex patients by having a face-to-face visit within 14 days for moderate and within 7 days for highly complex patients. If you're not aware of these, this TCM services can be provided by MD, DO, NP, PA, CNS, or CNM, and sepsis is one of the big four. It has involved in 12% of the 1 million hospitalizations with unplanned readmission. So whereas heart failure is at 6.7, pneumonia is at 5%, COPD at 5%, AMI at 1%, back to sepsis is the highest readmission issue, and with the longest length of stay as well as all those items. I believe that CMS is going to make us focus on sepsis more. I think they're treading lightly as the guidelines evolve, and but I think they'll come back to this. So of the 19 million discharges for CMS, only 5.2% were linked to the TCM services. So this is an opportunity to recover lost revenue. They found in 2016 that TCM's transitional care management significantly lowered rates of readmissions among patients with readmission-sensitive conditions by about 25%. This is really good content that was shared by Tara Hatfield and Allison Bryan Jungles, and I just want to make sure you're aware of that for further inquiry. A few resources that we have out there for you are IHA Sepsis Awareness Toolkit information for 2018 and 19 and the webinars associated with that. The CDC has sepsis education available through their website, Sepsis Alliance. Each of the individual disease-specific causes of sepsis are highlighted in a brochure. You do have to give them their email. They just want to know who's accessing their data, but all of this material is readily available. The Roy Staunton Foundation has education for children, and of course the HIN. Two things that are within the HIN content that I want to point out that are available. I have access to a chart review tool that you can use to do 10 to 20 charts and take a focused look at if you have a low sample, low size of patients that you're actually abstracting for compliance with the bundle on. You can use this for chart review for three things actually. There's one chart review tool to identify opportunities for post-operative sepsis, the incidence. There's another chart review tool for identifying gap analysis in the emergency department, and another gap analysis for identifying events within your inpatient evolution of sepsis, occurrence of sepsis. So we've got two different chart review tools that I can send you should you be interested. Mentioned hyperlinks here for two videos. One was Life After Sepsis that I shared, and the other one's Sepsis in Older Adults. There was published information by Dr. Mitchell Levy, who was part of the original development of the sepsis bundle and the guidelines. Just do it. Implementation of sepsis bundles, just do it. And there's also a research agenda that's been developed in late 2018 for Surviving Sepsis Campaign research priorities. But note that the guidelines are endorsed by the National Quality Forum in your lower left area there, and it's NQF number 500, endorsed by NQF. What are we asking you to do? Please complete your survey by January 31st. identify our highest DRGs for readmission and address the sepsis needs. And also, that's in your own individual hospital, and specify sepsis discharge information for the patients and families. Sepsis education does not begin at discharge time. It begins much earlier in the process, every time you're talking to the patients. So, what I'd like to hear from you is a couple things. I'll open up the lines here. Two things I'd like to hear from you. What is the role of the sepsis leader at your hospital? Or what are the education materials that you are sharing, and how has that gone for your hospital? I'll open up the lines here. You may need to unmute your own lines in order to speak, but all lines are currently open, and we can open up for discussion. Any comments or expectations or needs as a result of this content? You may also type questions in the chat room, even if you liked or didn't like the webinar, or further needs for education.
Becky, this is Judy Brome from Clark. We at Clark
Hi,
we have really fallen down on this end of sepsis as far as education for the patients and families. And I'm fortunate that we've got a leadership rotation with one of the local universities here coming to Clark. And I have one of the seniors with me for 7 or 8 weeks, and this is what he's going to be looking at, our readmission rates, and helping us to develop sepsis education for our patients at Clark. So I'm excited about this one. This was a perfect topic for today with that coming on.
Excellent, Judy. I love that innovation. That's great use of students. This content is, it's not difficult. The resources are out there. It's just how are you going to collate it for your particular hospital and take a look at the data. That's exciting. Thank you for your input there.
You're welcome.
I also think that opens up the opportunity for nursing students to be working on sepsis within your hospital. What do they know about it? There is sepsis content that they're getting, but what can they do to improve care to our sepsis patients as they do their senior clinicals? Other comments about the role of the sepsis leader at your hospital? And Judy and Casey both are sepsis leaders at their hospitals and doing some great innovation work. Is there anything in the chat? Mm-hmm. I will go back to the sepsis question that we had about other duties and how many are doing other duties. What are your perceived needs? What opportunities do you see within your hospital? You don't even have to mention your hospital name, you just speak out. But what do you see as the greatest opportunities? Slightly timid bunch.
I still think there's opportunity for physician education. I think a lot of the hospitalists, if you went up to them and asked them to tell you the 3 and 6 hour bundle, they could not tell you what the indications are for the fluid boluses.
Good commentary. Physician engagement. That has been a topic of conversation within our the state task force, and I think that we will circle back to that. I think that actually the physicians are very engaged on the task force, and that's going to make a difference in the state and how we lead this education process and engagement. I'm excited about it. I haven't seen the physician engagement to occur naturally. It's not an evolutionary process, but I think because of their presence on the task force, it's going to happen. I am an optimist eternally, but thank you for that comment.
Becky, this is Deb Joseph from Lutheran Hospital. Can you hear me okay?
We hear you, Deb. Thank you for calling.
Okay. So what we've done, we had a resident with our family medicine that wanted to do a project, and we went ahead and established a survey so that we can kind of get an idea of baseline understanding of the process and for identification and also of the protocol. So that's going to be coming back to us here soon at the end of January, and that'll help us just identify, what areas are the greatest, where do we have the greatest need for education, what components. So I'm looking forward to that.
Is that a physician, Deb?
Actually, it's physicians, nursing, and also our CDI, because a lot of times they're so instrumental in helping us with getting queries and stuff to identify whether it's really sepsis or not, and I want them to be just as aware as, the physicians and nursing on what to look for.
That's excellent, Deb. You brought up a key point that I didn't touch on, and I haven't really delved into that, except it is included on the survey, about the role of clinical documentation improvement integrity processes towards getting sepsis documented correctly, not only for the coding process, but also for bundle compliance. We can do better. It's not rocket science. We just need to be sequential in meeting these criteria and using the tools to help people. I'm very excited about, I hope you publish or at least share with us the results of your survey, because I haven't seen anything like that out there. It's very hard to get this information out of the literature. Great. Thanks, Deb.
Yep.
Anyone else want to share? All right, we will call it a day, and I thank you so much for your input here. The references are at the end of the webinar, but just know that your team here is available for you at the Indiana Hospital Association. Casey religiously sits next to me in these webinars to handle the tech, so that I can speak without messing anything up. So thank you so much, Casey, and we look forward to seeing you at our next webinar on February 11th, where we will talk about sepsis prevention. We touched on a little bit, but there will be more to talk about, and I may reach out to some of you for content from you. So thank you, and hope you have a great day, and thank you for being a part of our webinar today.